Hi, everyone. This is Dr. Escobar with Zach, one of the third year medical students. And we're going to be going over the hypothesis driven history taking for your first session of physical diagnosis. So, the learning objectives for this session are first for you to be able to reproduce a systems based overall approach to dyspnea and be able to categorize the diseases that lead to dyspnea based on what we consider to be an anatomic approach, and also be able to fully characterize your standardized patient's complaint of dyspnea. And finally, we're going to be reviewing some of the illness scripts that are going to be important for you in diagnosing the cause of a patient's dyspnea, and we would like you to be able to use that knowledge that you have. So, whenever I think about a patient who comes in with shortness of breath or dyspnea, I start off with a systems-based approach where I think about the cardiac causes of dyspnea, the pulmonary causes of dyspnea, and what I consider to be the miscellaneous causes of dyspnea. So first, Zach will just tell you a little bit about what features of dyspnea should always be elicited as part of the HPI.
Great. So some of these are true for any type of symptom. You want to get a sense of what the onset was. So was this a sudden onset or a gradual onset? What the pattern is of the symptom. Is it episodic or continuous? Is there any progression, meaning is it getting any worse? Or maybe it's getting better or staying the same? You want to get a sense of what the patient thinks the severity of the symptom is. You can have them score it on a 1 to 10 scale, 10 being the most severe. Get a sense of the duration. How long has this been going on for? Specifically for dyspnea, you want to know if this is worse during the daytime or at nighttime. Maybe it's worse when they're lying down at night for going to sleep. You want to know if the patient has any change in their exercise tolerance. Here in the city, we often measure that by the number of city blocks that they're able to walk. You want to know if there's any precipitating factors that the patient can identify. Maybe the weather, maybe something that they eat, maybe a new medication that they've started. And you want to ask the patient if they've noticed anything that makes it better or worse. Maybe if they tried something at home that can help you understand what the underlying cause is.
Great, Zach. So when I think about our first system, which is a cardiac, one of the ways that I begin to break it down is thinking anatomically about the different components of the heart. So we think about the myocardium, so thinking about heart failure. We think about the endocardium, which we think about valves. So we think about valvular stenosis and valvular regurgitation. Most commonly, you would be considering the atrial and the mitral valves. Think about the coronary arteries. So ACS is one of the diseases we want to rule out. And think about the conduction system. So is the patient having bradyarrhythmias and tachyarrhythmias? And finally, thinking about the pericardium. So are there symptoms suggestive of cardiac tamponade or constrictive pericarditis? And so Zach will now go through and review some of the illness scripts that you most likely have already learned from your previous courses related to these diseases.
Great, so we'll start with disease of the myocardium. Here it's congestive heart failure. You can think about the illness script as falling into 3 categories of pulmonary symptoms, symptoms of fluid retention, and symptoms of forward failure, meaning decreased cardiac output. The pulmonary symptoms that you'll see in these patients, they'll have shortness of breath, they'll have orthopnea, they'll have PND, and they'll have a dry cough. For their fluid retention symptoms, they may complain of lower extremity discomfort, they might complain of abdominal fullness or abdominal pain, and if you ask about it, you might find out that they have decreased urine output due to decreased blood flow to the kidneys. Some of the risk factors to keep in mind when assessing a patient's risk of developing congestive heart failure is coronary artery disease, diabetes and hypertension, and it increases with age. Congestive heart failure is relatively common in the Framingham study. There was a lifetime risk of 1 in 5 once patients reach the age of 40. So anyone who comes with dyspnea, this should be on your differential. Next is acute coronary syndrome. The illness script here, you'll hear the phrase typical angina, which is a patient who meets all 3 of these symptoms: acute substernal squeezing or crushing chest discomfort. It's provoked by exertion or emotional stress, and it's relieved within minutes by rest or nitrates. Some additional features of patients with ACS include shortness of breath. They may have radiating pain, especially to the left jaw and the left arm. They may have abdominal discomfort. They may complain of a cold sweat and lightheadedness. Some of these risk factors are similar to those of congestive heart failure. In addition, tobacco use is important, dyslipidemia, and peripheral vascular disease is really important, since this is really just vascular disease of the coronary vessels. And this is also prevalent in society. Coronary heart disease has a lifetime risk of about 49% for men and 32% for women in that same Framingham study. Moving on to the valvular disease. You can think about valvular disease as having different presentations, whether it's on the right side or the left side of the heart. On the right side of the heart, blood isn't able to get into the lungs, so it's backing up into the periphery, so you're going to have abdominal leg swelling, and of course you'll have fatigue and shortness of breath. Compared to left-sided heart valvular disease, you're not going to have the same kinds of pulmonary symptoms, since the pressure backup isn't going into the lungs. In contrast, left-sided valvular disease, you'll see that same shortness of breath and fatigue, but in addition, you're going to see prominent pulmonary symptoms such as cough and orthopnea. The risk factors, they mirror some of the ones that we've already described for other types of heart disease, but in addition, you want to look for history of infective endocarditis, rheumatic heart disease, and also heart failure. Not as common as some of the other illness scripts that we've talked about, but it's still an important item on your differential. Next is diseases of the conduction systems. This is any kind of arrhythmia. The symptoms and the illness script is going to depend on what exactly the arrhythmia is, but you'll often hear about shortness of breath, palpitations, or patients sometimes call it a heart flutter, along with fatigue and dizziness due to decreased cardiac output. The timing of arrhythmias is oftentimes episodic for atrial fibrillation, or it can be constant for diseases like heart block and sick sinus syndrome. And the duration will also vary. It can be from seconds to hours for AFib, but it can be more chronic for heart block and sick sinus syndrome. And the risk factors for arrhythmias, it's any kind of structural heart abnormality, which can be acquired or can be genetic. Arrhythmias increase with age. There's many medications that affect conductance, along with alcohol and thyroid disease. And then arrhythmias are also relatively common, lifetime risk of 1 in 5 once reaching age 40. For pericardial diseases of the pericardium, we're going to talk about tamponade and constrictive pericardial disease. I think about this in two different buckets. First is you're going to have impaired cardiac filling and output because the heart just isn't able to open up, so it's not able to push any blood out either since it's not filling. These patients will have weakness, they'll have it'll be mixed between right-sided and left-sided heart failure, so you'll see abdominal extremity swelling, chest pain, and you can even have loss of consciousness if it's severe enough. And these patients, they'll have some kind of inciting event that causes their pericardial disease. These you can lump into acute, subacute versus chronic. So acute causes would be any kind of trauma. It could be aortic dissection that backs up into the pericardium. Subacute inciting events include viral infections, lupus, tuberculosis, and then patients with mediastinal radiation can develop constrictive pericarditis as well. The risk factor is going to really depend on what the inciting event was, and pericardial disease is relatively uncommon compared to those other causes of heart disease. But of note, about 9% of patients with acute pericarditis will go on to develop constrictive disease.
As you can see, when you're thinking about somebody with a potential cardiac cause of dyspnea, there's a lot of overlapping features in the symptomatology. So what you ought to really think about is, although there are some similarities in the symptoms, there may be some differences in terms of the onset of it, whether it's acute or chronic, and certainly the epidemiologic features can be very helpful in distinguishing the different diseases from each other. So moving on to the other big bucket we think about, it's going to be the pulmonary diseases, of which we can also use an anatomic framework for further classifying these diseases. So I think about diseases of the airway, diseases that involve the alveoli, the interstitium of the lungs, the pleura, and then the vasculature. So once again, Zach will go over the different diseases in greater detail. You can begin to think about the illness scripts again.
Great, so we'll start with airway diseases, and this bit of a heterogeneous collection of diseases, but structurally they're all defined as taking place in the airways. The airways get separated into the upper airway and the lower airway. Disease of the upper airway tend to be more acute, responses to allergy, infection, or aspiration, and these patients have difficulty inhaling fully. Versus lower airway diseases such as asthma and COPD, these are more typically acute exacerbations of a chronic disease where patients can't exhale fully in COPD. They'll have chronic cough, chest tightness, and if it gets worse, they can develop cor pulmonale, which is right heart dysfunction due to this chronic lung disease. And the risk factors, it's going to depend based on which of the particular diseases they have in their airway. Asthma is associated with atopy. COPD is strongly associated with tobacco use, and there'll be various other exposures that can cause these things. And the prevalence is relatively common, so again, this should always be on your differential.
Yeah, particularly when you're dealing with the winter months when viral infections are very common, you're always going to think about asthma and COPD in your differential of anybody who comes in with shortness of breath.
Next, we're going to talk about diseases of the alveoli. This can include pneumonia and pulmonary edema. In both of these two conditions, you have fluid in your alveoli, so it's going to cause shortness of breath, orthopnea, PND, and a dry cough. In pneumonia, it's due to an infectious etiology, so you're also going to see signs of infection, which are fevers, chills, malaise, and you're going to actually have a productive cough in the setting of pneumonia. Some of the risk factors, it's going to be congestive heart failure for pulmonary edema, being immunocompromised for pneumonia, aspiration events can cause pneumonia, and as with a lot of these other things, it gets more common with age. And the prevalence, it's a common cause of hospitalization. Next is interstitial lung diseases. So these can be progressive, so you can go from exertional dyspnea to also having dyspnea at rest. Patients with interstitial lung disease will often complain of a persistent non-productive cough and fatigue. Depending on the etiology, there might be some kind of underlying disease. So if there's a connective tissue disorder, in your review of systems, you might find out the patient also has joint pains, help try to figure out what is going on. But there's other causes of interstitial lung disease like idiopathic pulmonary fibrosis where there aren't any other systemic symptoms that you're going to find. Some of the risk factors, it's broad. You can have genetic or idiopathic causes. Tobacco can exacerbate these conditions, and you want to look out for all sorts of environmental exposures and medications that you learned about in your pulmonology unit. And the prevalence really depends a lot on geography. The genetic etiologies are relatively rare.
Yeah, certainly in the hospital, we often these patients will often come in with some previous diagnosis of IPF, and they often will come into the hospital with some type of exacerbation. So infectious etiologies are also, once again, going to be very common in these patients.
Structurally, we're going to next talk about pleural lung disease. We're going to talk about pneumothorax and pleural effusion. The types of symptoms that you're going to hear about when a patient comes with pleural lung disease, first going to be pleural irritation. So it's going to hurt essentially when the patient takes a deep breath, unlike if the disease is just limited to, say, the alveoli, where the pleura aren't irritated. These patients, they're not going to be able to fill their lungs all the way because there's something blocking it, whether it be air in a pneumothorax or a fluid in a pleural effusion. So you're going to have symptoms of impaired ventilation, so dyspnea, exercise intolerance. And in a tension pneumothorax, not only can the lung not expand all the way, but the heart can't expand all the way either. So you're going to see the same set of symptoms that we talked about in cardiac tamponade. And the risk factors can include heart failure for patients with effusion. Trauma and mechanical ventilation can cause pneumothorax. And something to keep in mind is that a spontaneous pneumothorax can take place due to rupture of an air bleb in an otherwise healthy, tall, underweight, tend to be younger patient. And next is vascular lung disease. So we're going to talk about pulmonary emboli and pulmonary hypertension. Pulmonary embolism, the typical story is a patient has sudden dyspnea. They can't breathe all of a sudden. They have, at times, pleuritic chest pain, but that's not necessary to see. And these patients, if it's severe enough, they'll have a lot of sweating, anxiety, a sense of doom if it's a large pulmonary embolism. Compared to pulmonary hypertension, this tends to be more chronic dyspnea associated with fatigue and dizziness due to that high pressure in the pulmonary vasculature. That pressure can back up to the right heart, and you can see the symptoms of right heart failure that we talked about in some of the other illness scripts. There's a lot of important risk factors specifically for pulmonary embolus, such as a lot of causes of hypercoagulability. These can be genetic. Maybe they have high estrogen due to medication use. Cancer causes hypercoagulability. Nephrotic syndrome can cause hypercoagulability. Immobility can cause DVT, and if they have a known DVT, you definitely want to have a PE on your mind. For pulmonary hypertension, there's a lot of different causes of pulmonary hypertension. You can have genetic etiologies. You can have left heart disease causing that pressure back up into the pulmonary vasculature. And you can have COPD. It's a primary pulmonary disease, but it causes vasoconstriction of the pulmonary vasculature. The prevalence of DVTs and PEs, they're found in up to 2 people per 1,000 per the CDC. And pulmonary hypertension, because there's a lot of causes of it, the prevalence really depends on the etiology.
Yeah, now we're going to go to the miscellaneous causes that you ought to think about when you're thinking about a patient with dyspnea. A lot of these you actually won't be able to really discern just by history, because you will often find them on laboratory findings, but let's just go through them quickly. It's anemia, metabolic causes, toxins, central nervous system or peripheral nervous system, and psychogenic.
So first, we're going to talk about symptomatic anemia. A lot of patients are anemic, but they don't have any symptoms of it, so you want to differentiate them from patients with symptoms from their anemia. Oftentimes, those symptoms will be chronic exertional dyspnea and fatigue, and of course, we're in the approach to dyspnea unit. These patients might have muscle cramps, pica, which is seen in iron deficiency anemia specifically, and in severe anemia, you might see worsening angina. Some of the risk factors for anemia, because there's so many etiologies, again, it really depends on which of these we're talking about. For autoimmune hemolytic anemia, they might have underlying lupus, they might have a recent viral infection. You can also have drug-induced autoimmune hemolytic anemia. Anemia due to some kind of nutritional deficiency can be due to poor diet. Patients with a mechanical heart valve will often develop a hemolytic anemia due to the shearing of the red blood cells when it crosses the mechanical heart valve. And there's many causes of blood loss, both acute and chronic, that will over time lead to an iron deficiency anemia. And the prevalence, again, is quite variable. Patients with dyspnea might be due to an underlying metabolic disease. One of the more common ones is hyperthyroidism, where you'll see dyspnea at rest, and during exercise, you'll see fatigue. During your endocrine unit, you probably talked and learned a lot about the different manifestations of hyperthyroidism, including heat intolerance, sweating, nervousness, anxiety, impaired concentration, insomnia, palpitations, and weight loss, among many others. There's also some of the risk factors here. We'll talk about risk factors for hyperthyroidism. It's much more common in women than men. Patients will sometimes have a family history of it. Kind of a separate condition altogether. It can be different causes of metabolic acidosis, but similar to hyperthyroidism can also cause dyspnea. And those patients, one thing that you'll either notice on your physical or hear about in the history is a compensatory hyperventilation in your renal unit. You learned about the different causes and what to look out for. The next miscellaneous cause of dyspnea is toxins. We'll talk about carbon monoxide and methemoglobinemia. In carbon monoxide poisoning, patients will complain of headache, dizziness, weakness. They may complain of GI symptoms and vomiting, confusion. And in methemoglobinemia, some of those symptoms are similar. You'll also see poor muscle coordination and characteristically blue-colored skin. And the risk factor, of course, for toxins is going to be toxin exposure. For carbon monoxide, that might come from a wood stove in the home, a car running in the garage. They might be someone who was trapped in a fire. There's also a possibility of a public transportation emergency. Methemoglobinemia, it's caused by ingesting something, a medication. There's also genetic underlying causes. Second to last are neuronally mediated dyspnea. So these patients, they have a muscle weakness, whether it be, depending on what the exact disease is that's causing weakness of the muscles of respiration. So you'll see poor ventilation that will cause exercise intolerance. It can progress all the way to respiratory failure. And you can also see other muscles that are weak. In myasthenia gravis, you'll see oculobulbar weakness oftentimes. The patient may complain of double vision. In Guillain-Barré syndrome, you'll see an ascending symmetric pattern of paresthesias and muscle weakness. Some of the risk factors to look out for in your history. For MG, it's going to be a history of autoimmunity. Maybe there was a known thymoma in that patient. And in GBS, classically, it's a previous bacterial infection, notably Campylobacter. And then lastly, we'll talk about the psychogenic causes of dyspnea. These are most often going to be in the anxiety disorder bucket, and especially panic disorder. So the symptoms of psychogenic dyspnea is going to be a very sudden, episodic case of dyspnea associated possibly with palpitations, sweating, trembling. Patients might complain of chest pain, abdominal pain, nausea, vomiting. There's going to be a lot of different symptoms maybe that are all coming together. Patient may also complain of derealization, depersonalization, where it either feels like the world isn't quite real or they're not quite themselves, and they might complain of a fear of dying. Maybe that patient went to the ED in the past and got a negative workup that might clue you in that it might be something similar to that. Some of the risk factors for these anxiety disorders include family history, major life stresses that are going on, personal history of trauma or past abuse, and smoking and excessive caffeine consumption can also increase your risk. The NIMH and NIH, they estimate that the prevalence of panic disorder is about 2 to 3% of all U.S. adults, so it's something to consider.
Yeah, definitely. And I think, as a person who works in the hospital, whenever I see patients with dyspnea, I always think about anxiety disorders. But I feel like my role is to make sure that it's not an underlying medical disorder first. So in some ways, we think about psychogenic dyspnea as a diagnosis of exclusion. So I just wanted to go over show you once again the approach to dyspnea. Dyspnea is a very, very common problem that you're going to be encountering in the hospital during your clinical rotations. So it's really important to actually have this framework down. I know it's a lot of information. So what I typically do when I see a patient with dyspnea is I usually go through systematically the different diseases that we've mentioned already, and just kind of check them off one at a time. And one of the things I want to highlight is the importance of not only coming up with the most likely diagnosis, but also making sure that you cover the other less likely causes and asking questions that actually will help rule those out or help make them less likely in your differential. So the other thing I want to remind you is that the history is only the beginning of your data gathering as you try to figure out what's going on with your patient. And you're going to couple your history with the physical exam and the laboratory data. And based on that, you're going to then make a final diagnosis as to what you think is the most likely. So thank you, Zach, for reviewing with the students again the different illness scripts for these diseases. And as a challenge to you guys, I'd like to ask you, as you move on to the physical exam, what parts of the physical exam do you think you'll need to focus on when evaluating a patient with shortness of breath? Thank you very much.